So Olaparib Expanded is a phase 2 study. It's a PI-initiated phase 2 study that evaluated the PARP inhibitor Olaparib in patients with metastatic breast cancer who had either a germline or a tumor somatic mutation in one of many genes that function in the DNA damage response and homologous recombination pathways other than BRCA1 and 2, or in patients who had somatic BRCA mutations but did not have a germline BRCA mutation. So as a little bit of background, we know that PARP inhibitors, Olaparib and talazoparib, are approved for treatment of metastatic breast cancer in patients who have germline BRCA mutations, but they're not approved for any other patients with breast cancer at this time. So our hypothesis was that Olaparib would have at least a 20% response rate in the populations that we were studying. Again, those with the germline or somatic mutations in these other genes, or those with the somatic BRCA mutations. So patients received Olaparib, all patients did, at 300 milligrams BID until tumor progression or unacceptable toxicity. And we had one cohort for those with the germline mutations and a second cohort for those with the somatic mutations, including BRCA1 and 2. So there were 27 patients in each cohort, and the study required that there be 4 responses in 27 patients within each cohort for that cohort to reject the null hypothesis, namely a response rate less than 5%. So notably, about 85–90% of the patients who enrolled had a mutation in one of the 5 most common genes, which would be somatic BRCA1 or somatic BRCA2, germline PALB2 mutations, or ATM or CHEK2 mutations. So those were the most common genes and comprised the vast majority of the patients in the study. So the results showed that first, for the germline cohort, there were more than 4 responses. It passed its requirement. But what we found was that the responses were extremely gene-specific. All the responses were in the patients who had the germline PALB2 mutations. So for those patients, the response rate was 82%. In fact, every one of the 11 patients with a germline PALB2 mutation got some benefit. 9 of them actually had a partial response. 1 had stable disease over a year, and the last one has tumor regression, but not yet qualifying for a PR. So really a home run in patients with germline PALB2 mutations. Notably, no responses in the patients with the ATM and the CHEK2 mutations or other mutations. In the germline cohort, there was 1 patient who had a germline RAD50 mutation who had stable disease for about 6 months and then progressed. And then switching gears to the somatic cohort, again, response is very gene-specific. All of the confirmed responses were with patients who had somatic BRCA1 or 2 mutations. And for those patients, the response rate was 50%. And not seen with the other genes, although again, 1 patient with a somatic CDK12 mutation who had stable disease again for 6 months and then progressed. People would ask, what about somatic PALB2? We had 2 patients enroll in the trial who had somatic PALB2 mutations, and unfortunately, we didn't have more or a lot of assessments. One of the patients progressed at 12 weeks. The other patient appeared to be responding at the first tumor assessment, but then was lost to follow-up. So we really don't have as good a grip on somatic PALB2 and whether that's a predictor of response. I should add that the responses, we saw long responses. In the germline PALB2 patients, the median duration of response was 9 months, and the upper limit of the confidence interval can't yet be calculated. And for the somatic BRCA mutation carriers, again, the median duration 6.3 months, upper limit not yet calculable. So very gene-specific responses, germline PALB2 and somatic BRCA. We didn't see any responses in other genes, but really didn't have enough patients for any one particular gene to definitively assess the response to Olaparib. A few other points, we did see responses across all breast cancer subtypes. So estrogen receptor positive, HER2 negative, triple negative, one patient with HER2 positive. So just like in the germline BRCA carriers, I think responses are seen in all breast cancer subtypes. In terms of toxicity, don't think we learned anything really new. Olaparib was very well tolerated. The side effects were consistent with previous reports, namely nausea and anemia were most common. Of note, alopecia is very rare, and if it occurs, it's very mild. So we only had 15% of patients who required a dose reduction and about 4% of patients who came off study due to toxicity. Another point to make is, I'm asked, well, how many breast cancer patients have these mutations, for example, in germline PALB2 or somatic BRCA mutations? And I'd say PALB2, probably about 1% of breast cancer patients, but somatic BRCA mutations occur in up to about 4% of breast cancer patients. It may be more. The data we have is typically from analyzing the primary breast cancers, not metastatic biopsies. So it could even be more. So I think that, before this study, really germline BRCA carriers were the only breast cancer patients for whom we knew PARP inhibitors work, and they represent about 3 to 5% of breast cancer patients. So here we have another probably, 4 or 5% of patients for whom PARP inhibitors might be effective. So what's the next step? Well, right now, we can't write for PARP inhibitors off of a study for these patients. We ourselves are beginning 2 new cohorts to expand on our results. We're going to be specifically looking at metastatic breast cancer patients who have the germline PALB2 or somatic BRCA mutations, and we're going to confirm the responses we've seen. We're also beginning to analyze all of the specimens collected from the first study, and of course we'll be analyzing those from the new cohorts to really look for those biomarkers of response and resistance, whether they're going to be mutational signatures or functional studies. But I think it will be very, very helpful to find those biomarkers, because it really would not be feasible to do this kind of study for every single gene, RAD51C or D. We can't do a whole study. So alternatively, if we can find some biomarker to screen breast cancers, that would be very, very helpful. I think, other questions we want to look at is for the germline carriers, is LOH in the tumor necessary? Or for patients who have the somatic mutations, for example, even the BRCA mutations, is the mutant allele frequency in the tumor important? And of course, we want to analyze reversion mutations, because that's one important mechanism of resistance to PARP inhibitors in those with germline BRCA mutations. Is that also operating in patients with germline PALB2 or somatic BRCA mutations? So I would say those are the main findings of our study and where we hope to go from now.